So, good evening, everyone. Today is day 8 of the Golden Jubilee series, and today we are going to discuss about a combined Phaco Trab. So, good evening, Satyajit.
Good evening.
So today we are going to discuss about a combined Phaco Trab, and what I routinely do is that I start by making the conjunctival peritomy in the superior quadrant, because I'm going to do a temporal phaco. So the trab will be done in the superior part. Normally, I don't combine in the same site. Both sites are at a different place. So remove the conjunctiva as well as the tenons. Create a small pocket. And then cautery is done to cauterize all the bleeders. It's wet field cautery using the forceps. It should be done lightly, not very, should not scar the sclera, just enough to prevent any bleeding from the incision site. And then routinely I use the crescent knife itself to create the flap. Partial thickness scleral flap is being made using the crescent knife. Usually the patient has a little bit of cataract also, and is medically uncontrolled with medication or has advanced glaucomatous cupping. I combine the two procedures in one go rather than doing tab first and then doing FIC later on. In my hands, FIC, a combined procedure works better than done separately. So after we've made the flap, we are going to place the sponge, a Vexil sponge, which has been wetted with mitomycin C. So here the Vexil sponge goes in. It has been made wet using mitomycin C. I use 0.4 percentage of mitomycin C. And it is placed so as to cover the entire area where you want its action. So once we've got these sponges in place, then it's like this for 3 minutes. I keep it for 3 minutes. And after 3 minutes, the sponges are removed, and about 20 cc of saline is used to wash this area properly. This is most important because mitomycin C is toxic, and if you get even a little bit of it inside the endothelium, it's going to harm the endothelium. So make sure that you do a good wash, a thorough wash of the area where you have placed the mitomycin C. As I said, use about 20 cc of BSS or saline or ringer lactate, whichever solution you're using. Of course, I use BSS more often. Now I've shifted my position already to a temporal site. So the side ports being made using 20 gauge MVR blade. And then, sorry. So now whatever steps are being done, these are all very routine, putting in air inside the anterior chamber and then staining with trypan blue under air. And as I've said in my previous episodes, routinely I wash the dye from the opposite side port just to give it a little bit of stain. So it makes it easier to locate when you want to use your chopper or whichever instrument from the opposite end. So using your 2.2 baritone, this is what I routinely do, make a small groove at the limbus and then enter the anterior chamber through that groove. And then a slight enlargement of this 2.2 per 2.8, 2.2 to 2.4. This is the Gaurav Luthra's Rexis marker. And then using your 26 gauge needle, which is bent as a cystotome. So again, very routine is what we routinely do. I'll just speed it up a bit. So the Rex is being made following the mark that we've made on the cornea. It's not very visible right now, but just a small impression that we get on the cornea is enough to give you a approximate size of the axis to 5.5. Then hydrodissection, hydrodelineation, rotation of the nucleus. So I routinely try and rotate the nucleus a bit while I'm doing the hydro. Then viscoelastic is placed in the anterior chamber and we are good to go for Phaco.
ड्राइवर साहब आ जाएंगे तो बोलना.
This is a 2.2 sleeve.
Can I ask you a question?
Yes, yes, sure.
You had made this 2.4.
Yes.
When you actually have a Phaco probe and a sleeve which will fit into 2.2, why did you extend it?
For precisely the reason that you're seeing now, that sleeve, sometimes doesn't go in a 2.2. After becoming a slightly loose, I find it difficult to insert it. So what you saw me struggling with was because of the sleeve. Sometimes even the sleeve, the usage becomes a little loose. So that is why I enlarge the incision a bit. And then because I have to implant an Indian IOL, that cartridge size will not go into a 2.2, but will go into a 2.4 and give me a wound assisted delivery of the intraocular lens. So that is the reason why I make it 2.4. And I don't enlarge it completely. I enlarge at the limbus and leave it 2.2 inside. The inside part of the incision is 2.2 only. Only the outer one is 2.4. But then I believe it does expand to a 2.4 throughout once the phaco.
Any particular reason why you do a 2 point surgery, one for phaco and then another for trap, not a same point entry?
Yeah, the reason being is that I find it slightly more difficult to maneuver my handpiece through the flap of the trab. You can't, at least in my hands, doing it in the same. I've tried to do it in the same port, but somehow I'm not very comfortable in using the same port for doing phaco as well as doing the trab. So that is why it is always two-sided, temporal for the phaco and superior, obviously, for obvious reasons.
भेजा वो एक बार पकेगा तो दोनों दिन पर आ जाएगा।
So this is, as I said, very routine phaco chop, vertical chop with lateral separation, and getting all these fragments emulsified.
कुछ ला क्या मंगवाई हो?
Not a very hard cataract. It's about grade 2, grade 3.
पैसा निकला।
Can you mute everybody else? Mute all.
So all the fragments, once they are chopped properly, it's easier to just simply allow it to come into the phaco probe, and they are emulsified.
नहीं तो कॉल भी आता है ना, आगे नहीं लेने पर कॉल आया, बोल दीजिए कि भैया उसको कैंसिल कर दीजिए कि मैं खुद.
And then before I come out, as I always do, I inject viscoelastic to the opposite port, side port, just to maintain the anterior chamber. So this is followed with your bimanual irrigation aspiration, and almost all the time I'm able to get the most of the cortex out without having to change my hands. But then if it is very sticky, you need to change your hands. So you just saw me, I held the posterior capsule coming out. If you hold the posterior capsule, don't try and persist. Just simply change your hands. Loading of the intraocular lens, again done under microscope by myself, always. Make sure to have the haptics in place inside the groove so that they don't get caught. Oops. Sorry. So this is basically a wound assisted. It is just inside the wound and then gets delivered inside the anterior chamber. So if it were to be a 2.2, this would have been very, very difficult to do. A wound assisted with the Indian cartridges, which are not meant for 2.2. Once we've implanted the intraocular lens in the bag, let's go wash, remove all the viscoelastic from in front and behind the intraocular lens. Now again, we need to change our position. Come back to the superior. Now I'm sitting superiorly. Bit of air.
At this point of time, you don't put pilocarpine?
Just I put air and then I put the pilocarpine. Now using same 2.2 keratome, the incision is made to enter the anterior chamber, and then I use a punch. This is a glaucoma punch. To get a sclerotomy, and then we will make the peripheral iridectomy. Just wash.
इतना बढ़िया सर्जरी दिखा रहे हो, इसको तो हमको लगता है अमेरिकन एकेडमी में भेजा जा सकता है फॉर देयर वीडियोस फॉर ट्रेनिंग। बहुत ही बढ़िया।
So then make sure to remove all the pigments that you may have released while you are doing the iridectomy. Keep the chamber formed at all times, because these lab cases, if the pressure has been very high and if the patient is elderly, the chances of an expulsive hemorrhage is very high. So make sure that your chamber is always formed. Even if it is not fully formed, it should be formed by air so that it doesn't leak. And then I use 80 Vicryl to suture the flap. It's triangular flap. Many people make rectangular flaps. Where I was trained in Ahmedabad, the glaucoma surgeon used to always make a rectangular flap. But then in my hands, I think triangular flap is good enough. And this, while you're tightening this, make sure that you titrate the tightness of this, because this is where your major flow of the acts would be. So it shouldn't be too tight and it shouldn't be too loose. Just enough so that it just approximates and gives you a flow through the underneath the flap. So one suture at the apex, and then 2 sutures on the sides. So at this point of time, try and be very careful of not puncturing the conjunctiva, because if you create holes in the conjunctiva, the chances of leakage becomes higher. So be very careful while you're suturing this. For the sides, a single throw is good enough. And when you trim the mitral suture, it should not be too long, because if it's too long, sometimes it comes out through the conjunctiva. So it should be just enough to not get loosened and not too long also. So the whole surgery of trachelectomy depends on how you suture the flap. The flap is a very critical step in the trachelectomy surgery. The phaco is always as a routine, so one has to be very careful while suturing the flap and titrating the tension on the tightness of the suture. And now comes the other critical point, is suturing the conjunctiva. You must not try and suture the tenons. If you have separated the tenons, let it be in its place. If the tenons is very fleshy, then you may also remove part of the tenons. But if it is thin, you may just leave it. Many times, some surgeons remove the tenons also. But it depends from case to case which case requires the tenons also to be removed. So these sutures being placed on either side of where you have begun and ended your conjunctival peritomy at the limbus. And what you saw me doing was that I first went in from the other end, and then from, routinely you would go in from one side of the conjunctiva and come out. But here I have tried to bury the knot inside. So one suture I like to place just to keep the conjunctival uh, approximated against the limbus. So I like to do this step just to prevent any leak in the early postoperative period, because that is the period wherein the anterior chamber can become shallow, and you can have other problems related to the leakage of the aqueous. So if the conjunctiva is flush against the eyeball, the chances of leakage is lesser. So again, this is not very tight, just enough. So after having done this, now you would like to hydrate your wounds. And the hydration itself, now you can see some amount of ballooning of you can see aqueous, the fluid that you are injecting, it is coming into the subconjunctival space, which means that your Trab wound is working well. If you don't get to see a bleb forming, then it means that either the flap is too tight, or the sclerotomy is blocked, or the iris is blocking the sclerotomy. So make sure that it is blocked. It is patent. Sorry. So when I was injecting the fluid, I found that it was leaking from one side. Probably I punctured the conjunctiva at one place, so I don't want to leave that hole. So I'm suturing that hole, which was what I was alluding to. That make sure that you don't have a hole in the conjunctiva while you're suturing your scleral flap. When you test your bleb, make sure that it is watertight and not leaking. Got cut, so I'm having to place it again. Okay, so we're almost done with the surgery. I always use intracameral moxifloxacin at the end of the surgery. So again, hydrating the wounds and then putting in the intracameral moxifloxacin at the end. Okay. Wow, wonderful. So, any comments from Ranjan Rai sir? I see you here. Thank you for joining. Would you like to say something? How do you routinely do your Phaco Trabs? Or do you mind them, or do you do it separately?
I used to do it separately, dear.
You would do your Trab first and Phaco later, or do your Phaco first and Trab later?
Phaco first, Trab later.
Any particular reason for doing it separately?
This is my presumption that this same side Trab failure is more because of this Phaco burn and all, and excessive handling the limbs.
Yes, so that is the
But
reason
so
why.
many studies have shown that there's no difference.
No, but that is one of the reasons why I make two separate incisions for Trab as well as Phaco. I don't do a same side Phaco and Trab. It is done in a temporal Phaco and superior Trab. So you're
You
not.
did an amazing surgery. You did an amazing surgery.
Thank you.
But 1, 2, 3, 4.
Yes.
4 ports were made. Does that not make the eye more susceptible to end off?
No.
Versus making just 2 ports? And all the studies have shown that there's no difference between 2 entries and 1 entry.
Yes. So, the studies whichever are done, but what works best in your hands, actually that matters. Studies are good enough to go by, but many a times the surgery that one does, what procedure works best in one's own hands is what decides what you will do. Studies will guide you, but
हो जाएगा मैं
they are
अब
not
कब होगा
they are not the only criteria. So
That's true. That's true.
वो बता देगा मैं हो जाएगा हम खत्म कम कर देंगे
so
What extra you have made?
what
You
extra?
are already making 3 ports,
Yes, 3 ports
0.9
are-
millimeter side port and 2.2 or 2.8 millimeter of phaco incision.
Yes,
And that, mind it, trab incision is more secure because you are suturing it.
yes, yes, yes,
Chances of, and more so, you are covering it with the conjunctival flap.
yes, yes,
So chances of external infection through that area is almost nil compared to your ragged wound of main incision or side port.
yes, yes,
This is my perception.
yes,
So,
no, yes, yes, sir. Go ahead.
so it is, in my opinion, I say opinion varied. In my opinion, it is better to go for a two-side trap. And what you last step done, if there is any buttonholing or leaking of the you suture meticulously, that
Yes,
is
yes,
more important to failure as well as to prevent the external infection which is connecting from the environment.
yes,
That is
yes.
more important.
That is the reason why I said it, and I then showed it also, that if you have a buttonholing, make sure you suture it properly. If the suture gets cut, make sure to go back and suture it again. Your wound, the trachelectomy wound and the syntagma has to be secure and flush against the eye and not leaking, because that is very, very important. Not only to prevent infection, but also because you don't want a leaking wound and then having to deal with a shallow or a flat anterior chamber in the next, or the 3 days later you'll have a flat anterior chamber if it is excessively leaking. So uh, uh, normally I
How, Dr. Salam,
yes,
how do you assess your suture tightness while suturing the flap? I mean, when do you say that you have tied it, you have sutured it very tightly, or your sutures are loose while suturing the scleral flap?
the scleral flap is too tight, you will see folds. If the scleral flap is very tight, you will see folds in the cornea, in the superior part, if it is too tight.
Fine.
If it is too loose, you can see it. If it's too tight, you will see folds, which means that
Fine.
it is too tight. So one has to just make it tight enough, but not loose also, because that is where your drainage will be
So
occurring.
it should be easily buried. It should be easily buried while burying the suture.
Yes, if you're using a 10-0 nylon, you can bury it, but an 8-0 Vicryl, which I routinely use, doesn't get buried easily. So I don't try to bury it. I just leave it. If you have a good,
Don't you think that?
yes,
Don't you think that this 8-0 Vicryl is more reactive compared to 10-0 nylon, which is relatively inert? So chances of getting success or late fibrosis is less with the 10-0 nylon compared to 8-0 Vicryl.
somehow I think in my hands, Vicryl works better, and I don't really worry about the the fibrosis or the extra amount of inflammation at that site locally, because anyway you're going to give your topical steroids and even oral steroids. So the chances of inflammation, I really haven't had cases where the site is inflamed because of the use of Vicryl. Yes, sites can be inflamed uh, in the area where you have sutured the conjunctiva, but I haven't seen it with the flap. And I think that because Vicryl degrades faster, the failure rate in my hands is slightly lesser with Vicryl rather than with 10-0 nylon. So that is why I switched from 10-0.
What is the common practice of doing flap suturing? Is it 10-0 or 8-0 nowadays?
No, it is still 10-0.
Just for curiosity.
Yes, it is still 10-0. It is still 10-0 nylon. Maximum number of people use 10-0 nylon, and another reason for using,
yeah, go ahead.
Another reason for using 10-0 nylon is that if you are practicing releasable sutures, only a 10-0 can work with for a releasable suture. And I think maximum surgeons who are doing routinely glaucoma surgery, we are not doing routinely glaucoma surgery. We are doing, sometimes, 4 or 5 in a year. But those who do routinely glaucoma surgeries, they are using releasable sutures. That is why you need 10-0.
What should be the normal post-op regime in this Phaco Trab? Do you like to put patient on home atropine or simple tropical seal or cyclopentolate?
No, I don't put patients on any dilator